The broadcast is now starting. All attendees are in listen-only mode.
Good evening, everyone. This is Robbie Miller, Executive Director of Axis, and I want to welcome you to tonight's Axis webinar with the title of Promoting Good Health in Adults with XXY, or Klinefelter Syndrome. And we are very lucky to have Dr. Adrian Dobs with us tonight, who will be speaking to you. And I just want to say a little bit about Dr. Dobs. First of all, she and her clinic are members of the Axis Clinic and Research Consortium. Dr. Dobs is particularly interested in new forms of male hormone replacement therapy. She's published extensively in the area of hormonal changes with aging. Her clinical practice focused on sex hormone disorders in both men and women. And she, as director of the clinical trials unit, oversees a team of individuals dedicated to facilitating clinical research within an academic medical center environment. We're really lucky to have her here tonight. She'll be doing this presentation for you. She'll have time for some questions at the end of the presentation. Our webinar manager, Rick, is going to say a few things about asking questions, and then we will begin Dr. Dobbs' presentation. Rick, could you tell us how the best way to ask questions when the time comes to do that?
Hello, hi everybody. Okay, on your GoToWebinar panel, you should see a section named questions, and there'll be a little box under there, and at any time during the webinar you can enter your question, and I or Robbie or Dr. Dobbs will be able to see it, and then yeah, we'll get to those at the end of the webinar. Thanks.
Okay, thanks, Rick. Dr. Dobbs, the podium is yours, and thank you again for being here.
Great. So it is really my honor to be here. As it just introduced, my name is Adrian Dobbs, and I am an endocrinologist at Johns Hopkins. I take care of adults. So generally that means from the age of 16 or certainly the age of 18 up, I would be involved. And later on, I'll discuss with you the team that we have, which does include a pediatric endocrinologist as well. And as you know, Johns Hopkins is a hospital which exists in Baltimore, Maryland, which is on the East Coast. Okay, give me 1 second here. Do I have control of my slides? Please.
Yes, that would be within PowerPoint.
Hold on a second. Okay, great. So generally these are the objectives for this evening's presentation. I'll first discuss historical background and try to get a sense to the group of really what is Klinefelter syndrome or XXY. Discuss a little bit about how common is the syndrome in adulthood. Then I'll be discussing the clinical picture, particularly discussing some of the concerns that adults may face, that is obesity, metabolic syndrome, diabetes, bone disease, cancer, and some other comorbidities. And then I'll be discussing treatment issues. So to begin with a history, it was described in 1942 by Dr. Harry Klinefelter. And I would have to say in those times, they often named medical conditions after the physician that first observed this in a patient in clinic. Today, it doesn't happen as much because there's just so many names, it was almost impossible to remember. But somehow Klinefelter has stuck, so it's still a term that is used, although people might say XXY, or so it depends on the group that is being discussed. At that time when he presented the patient, the main characterization of this gentleman was that he had gynecomastia, which is enlargement of the breast. He had lack of facial and body hair, had small testes, and was found to be infertile. So it wasn't until 1959 that a woman named Patricia Jacobs, she was the one that really showed what the problem was. And the problem was that there was an extra small little X that these gentlemen had. So what really is it? So normally there are 23 pairs of chromosomes in each cell, including one pair of what's called sex chromosomes. And here you see a female generally has an X from the mom and a X sperm that comes from the dad. And a male would have an X sperm from the mom and a Y sperm that is coming from the father. So in Klinefelter's, it's most commonly due to this extra X chromosome, and it results in a karyotype called a 46XXY. And doing a karyotype test is really very common now. It's easy to get, and most labs that can get this result back within a few days. So this extra X chromosome is about half the time from the mom and half the time from the father. There are some variations that can be seen as well, and they sometimes call that a mosaicism, like a mosaic, and that not all cells will have the same pattern of the 46XXY. Some might have be the 46XY, and some are mixed. So there are some variations, and they call that mosaicism. So this is just a picture of what I just said. So Klinefelter can be due to an extra X coming from the dad, or it can be due to an extra X coming from the mom. And so how does this really affect hormones? So in many ways, we don't know this full picture. So what I have shown here is that this is the normal stimulating pathway for hormones. So here's the brain, and there's a gland in the brain called the hypothalamus and the pituitary, and they make these very important hormones called LH and FSH, and these normally stimulate the testicles to make testosterone and to make sperm. So the problem with men who have XXY is that they're 100% male because they have the Y chromosome, but the small X causes a problem, and the small little extra X causes a problem with development of the testicles, so that instead of the testes producing testosterone and sperm, they now somehow don't fully develop, so they're unable to make at least the same quantities of testosterone and sperm as seen with a man who would not have this extra X. So how common is this in adulthood? Well, the numbers do vary, and because it is hard to say how many boys are actually born with it, but overall, people would say that it could be as high as 1 out of every 450 men. And there's some variability in that frequency. Sometimes it's said to be 1 in 500 male births, and other times it's as high as 1 in 1,000. So this is not a rare disease. It's fairly common. And I always think of a football stadium in which there could be, easily 40,000 men there. So that means you might have as much as 1 in that, if you're saying 1 in 1,000, that means you'd have almost 40 men in that stadium that would have the condition. So it is not rare. The estimated prevalence in the newborn is about 152 per 100,000 newborns. Now, if you look at certain groups of men, like men that present to an infertility clinic, in this situation, it'll be more common to see men with Klinefelter syndrome. I always want to remind people that infertility is common in the world. It turns out that 15% of couples have difficulty having children, and of that, half is a male factor. That means 7.5% of men in the world have infertility. Men with Klinefelter syndrome just happen to know what the cause is. So if you look at men in a fertility clinic, obviously there's going to be more men who have a Klinefelter syndrome in that group. If you look at all men who have absolutely no sperm in their ejaculate, then it's even more common to have Klinefelters in the range of 10 to 12%. So certainly any man being evaluated for infertility, we tend to be very suspicious that they may have the Klinefelter's karyotype. There's some data that it may vary by geography, but it's not clear. And there's even some data that it may be increasing. And I think the main reason for that is really early detection, that we're seeing it more because more genetic tests are being done. But there is some data that Klinefelter's is more common in an older parent. So as the world, world which is more industrialized and wealthier, have children later in life, it is possible that we're going to see an increasing prevalence of having Klinefelter syndrome. Another reason that I want to highlight with the epidemiology is that it's often underdiagnosed. We may be seeing it more because of genetic testing, but still, so often men present late in life. They present in their late 20s or early 30s at the time of infertility. And it's this group that I feel that we have an obligation to, because in the future it really would be much better if we could diagnose these men earlier. So here is just a slide highlighting the fact that it is often underdiagnosed. And this slide looks at the prevalence of Klinefelter syndrome for 100,000 males. And it starts from the age of 0 and it goes all the way up to 60 to 69. And what you see here is that most men are diagnosed between the ages of 25 and 54. And this is because most men are diagnosed when they are interested in having children and they're found to have infertility. The goal would be really to start diagnosing boys and young men really at this side of the curve. So overall, the diagnosis of Klinefelter syndrome is commonly delayed and is commonly even underdiagnosed or undiagnosed completely in men. But regardless of the timing of the diagnosis, it is important to be aware that there are many medical conditions that might affect men with Klinefelter syndrome. And these are things that we need to be aware of to best prevent and treat any possible complications. So I'd like to talk to you about some of the clinical picture of these men. And I'm going to emphasize things that we sort of don't always talk about. There's no doubt that a teenager who with Klinefelter's will have delayed puberty, or at least they will not reach their maximum potential. And that is a scenario in which those patients are often brought to medical attention. I'm not really going to go over that part of it because it's basically clear that these are men that have either reduced pubertal changes or don't go through puberty at all. So what I'd like to concentrate a little bit more on are some of the other problems that we need to be concerned about. So this is a nice article by Groth in which they looked at some of the clinical features that can be seen in men with Klinefelter syndrome. So on top is the issue of fertility. And at least when we talk about if there's any sperm in the ejaculated semen, it turns out that infertility is extremely common, if not, and so infertility and full azoospermia is seen in more than 95% of men. This is a whole nother topic in itself, and we at Hopkins are very involved with discussing fertility with patients because of many of the new techniques available. It is now possible for men with Klinefelter's to have their own biological children. The numbers go on about 50%. But I always want to emphasize to a patient that there are many ways of being a father, and that infertility is something that it occurs for many different reasons, and there can be many ways of treating this and approaching the problem. But certainly it is common in this scenario. The other things that have been seen are in the second group here, let me go back, and it's the learning disabilities, and this is very variable. The data they found is that it might be as great as more than 75%. Some of this might be a delay in speech development. Some of it might include psychiatric disturbances. I would have to say, though, there's a fair amount of controversy about this, and certainly in a large clinic such as ours, we see these men who are just absolutely superstars, who've had no learning disabilities, and have extremely high-level professional lives. And I say this controversy because learning disabilities are so common in the general population. I think most would still say there's some learning differences in children who have Klinefelters, but I always try to emphasize to people that there's a wide range of abilities, as there are in all humans, and that the issues of learning disabilities have not fully been classified well. Another problem that can be seen sometimes is abdominal obesity in about 50% of patients, metabolic syndrome, which I'll talk about a little bit in detail, and full-blown type 2 diabetes has been seen in 10 to 39% of individuals. And again, I will talk about this a little bit more in detail. Osteopenia means thin bones. Osteoporosis is the extreme form of that, where the bones are really quite weak, and eventually this can lead to fractures, so that men who are untreated with testosterone have an increased risk, 2 to 40-fold increased risk of developing fractures. And most of this is in untreated men, because testosterone has a very strong role for bone density. Breast cancer can be seen in adults. There is an increased risk. We're very careful about teaching men about the issues of looking at whether or not there could be a development of breast cancer. And then from a hormonal point of view, there is an increased level of FSH and LH, which is seen in nearly all men, and a decreased testosterone level, which is seen in about 63 to 85% of men. So let's talk a little bit in detail about some of the metabolic problems that can be seen in men with Klinefelter syndrome. So the first thing has to do with their body fat. And what you see here is a graph. And this has to do with someone's body mass index, which is basically their weight. And here you see men who have a BMI less than 25. They're considered normal. This is overweight men, and this is obese. And this is the amount of fat that they have around their abdomen. In the solid dots are men who are what's called a control group, and in the open circles are men who have Klinefelter syndrome. And what you can see here is that men who have Klinefelter syndrome are more likely to be in the upper quadrant here. That is, they're more likely to be overweight, and they're more likely to have fat around their abdomen. Now, this is a problem because it can be associated with something called a metabolic syndrome. And a metabolic syndrome is defined by having at least 3 of the following criteria. One is a large waistline. Some people have called this an apple shape. The other is an elevation in cholesterol levels, which is associated with heart disease. And it could be either high triglycerides or a low HDL. A high blood pressure could also be seen in metabolic syndrome, and a high fasting sugar, and this could be an early sign of diabetes. So why does it matter if somebody has metabolic syndrome, including this obesity? And the main concern about it is that men that have this predisposition are oftentimes more likely to have diabetes. And diabetes is a very common condition in the world, worldwide, and is associated with many different kinds of complications, such as kidney disease and heart disease. And in fact, heart disease is the major killer for people who have diabetes, and that someone who has diabetes is twice as likely to develop heart disease. In fact, even if they have one risk factor, this will still increase the risk of developing heart disease. Some of the other risk factors that go with heart disease include this high LDL, often called the bad cholesterol, and most importantly is smoking. I just cannot talk about heart disease without saying that smoking is the worst killer of them all as a risk factor for developing heart attacks. So this is a slide that looked at on the left. These are men who have Klinefelter syndrome. On the right is what's called a control group. And this is the percent that had that medical problem. And in the yellow here are the metabolic syndrome, which I've already said is this constellation of 5 risk factors that go with the eventual development of diabetes. While compared to men who don't have Klinefelters, only 10% have metabolic syndrome, while in men with Klinefelter syndrome, 48% had metabolic syndrome. And here is diabetes in the dark green. So about 10% of men with Klinefelters has diabetes, compared to what's seen in the control group of men, which is only about 1 to 2%. So, and the strongest predictor of this metabolic syndrome is to have this apple shape, meaning fat around the truncal area. So diabetes, we know a lot about. It's a common disease. It's associated with blood sugar levels that are too high. We know that insulin will bring down that sugar level. Now, there is what's called type 1 diabetes, and in this situation, it's very severe. The body does not make insulin. That's not what we're talking about in men with Klinefelters. In men with Klinefelters, we're talking about type 2 diabetes, and this is the scenario that's very common, and this is associated with obesity in general. We found that it's important to monitor blood sugars, even in people who have what's called early diabetes, and that is because it's associated with so many complications, such as heart disease, stroke, amputations. So the diagnosis of diabetes is a very clear, is one that we take very seriously. But what we're talking about here is also preventing it from happening, not necessarily how to treat it once the patient has it. And the diagnosis is usually made by blood tests. It could be by measuring a blood sugar, or it could be by something called an A1C test. So here, again, is the issue of what is the risk of having diabetes. And the frequency of type 2 diabetes in men with Klinefelter syndrome can be as high as 10 to 39%. And this is the type 2 diabetes, again, the obesity kind of diabetes, the diabetes you get as an adult. It is not type 1 diabetes, the kind of diabetes that you get as a child. Here on the left, we've already said the metabolic syndrome was so common. Well, here is having either pre-diabetes or diabetes here versus a control group. Now, does this do anything? Well, there has been some suggestion that this may take off a couple of years of life. Now, in general, men with Klinefelters live to a nice, ripe old age. But if they develop some of the complications, that can interfere with the median survival of men with Klinefelters. So here you see is what's called a survival curve. And here 100% are alive. And as men get older with age, obviously there's going to be death that occurs. And there's 2 lines here. One line is what would be called a control group. The other line is men that have Klinefelters. So if complications do develop, such as diabetes, they will have a slightly lower median survival age than would a man that does not have any complications. These are some of the reasons that there could be a slight increase in mortality in men with Klinefelter syndrome. Lung cancer, breast cancer, diabetes, circulatory disease, stroke. These are things that we want just to be very clear that we're monitoring closely to make sure that there isn't a problem that is developing. Certainly a lot of people get circulatory disease, so we just want to be extremely vigilant in men who have Klinefelter syndrome to ensure that they are properly evaluated to prevent these complications from happening. So in summary, metabolic syndrome and diabetes is well described. Risk for developing this is increased fat or loss of muscle, and it is slightly more common in men with Klinefelter syndrome. We are concerned about this because it is associated with an increased risk of complications, including heart disease. And what can we do to reduce the risk of developing metabolic syndrome and diabetes? Well, first and foremost is a healthy lifestyle. And that means diet and exercise to maintain a normal body weight, to try to minimize fat. The other I've already mentioned, and that is avoid smoking. Smoking is the greatest risk factor for the development of heart disease. The other is screening tests. This is generally done. Done in the general population, and done in men with Klinefelters as well. The one is physical exam. We commonly look for changes in weight and how it's moving over time. We will commonly do a lipid panel so that if someone has excess high cholesterol level, this is something that can be treated fairly easily with diet or medication. And we would also do screening for diabetes, and this would include a hemoglobin A1C. Sometimes an oral glucose tolerance test would be done, or even a fasting glucose. So those are the few words I wanted to say about metabolic syndrome and diabetes. The next thing I'd like to talk about is bone disease. So bone disease, we use two terms here. One is called osteopenia. Osteo means bone, penia means small. And osteoporosis, again, bone, but now it's almost like a pore, like an opening. And the way we measure whether or not the bones are getting weaker is by doing a test called a bone mineral density measurement. And this is done by a special machine. You might think it's an X-ray test, but it's actually called a dual energy X-ray absorptiometry test. It's called a DEXA scan. And from this, the machine essentially does calculations to determine how thick or how thin the bones are, and they compare it to a healthy young person. So that we commonly think of osteoporosis for older people because osteoporosis occurs so commonly as men and women get older. So to make the statement that somebody has osteoporosis or osteopenia, we say, well, in comparison to a young person, there really has been a change in their bone density. So we know that there is an increased risk of developing osteopenia, osteoporosis in men who have Klinefelter syndrome. And we're concerned about this because osteoporosis is a risk factor for fractures. I think many of you may know that women can develop osteoporosis as they get older. And many men do as well. As women, it's considered due to the fact that they go through menopause, and at menopause, the estrogen level falls. And estrogen and testosterone, both of them are associated with strengthening the bones. So in women who don't have estrogen, this would result in this osteoporosis, and unfortunately, as they get older, it will result in fractures. And fractures are really a big problem, particularly in this country, as people get older, because once a fall happens, people rarely regain their same kind of strength and the same kind of mobility that they had before the hip fracture. And in fact, if you're dealing with very elderly people who are in their 80s, it's associated with increased death. Now, you know, when I say the word osteoporosis to someone who's 20, they just don't understand it or believe it can happen. But It's one thing developing osteoporosis when you're 80. It's another thing developing osteoporosis when you're 60. So that's the kinds of concerns that we have. Now, in men who have Klinefelters, there have been reports to decrease bone mass, and this has been seen in about 25 to 48% of cases. True osteoporosis has been reported in 6 to 15% of cases. And the thought is that there's an annual decline in bone mass that's approximately 1% at the lower back and at the femoral neck. The femoral neck is a very important bone by the hip. So we want to make sure that men with Klinefelters do not develop this progressive drop in their bone density. Now, there are some multiple mechanisms that might explain the reduced bone density. One is the issue of too much fat. The other is low physical activity. It's very important that we maintain muscle mass as we get older. This is really the case for everyone, but particularly people who are at increased risk of developing osteoporosis. So it's not just running and aerobic exercise that's important, but it's also lifting weights to maintain muscle mass. The other contributing factor is vitamin D levels. It turns out that vitamin D levels help to strengthen bones. Many people don't drink dairy products. Many people don't go out in the sun. So in the United States and in various parts of the world, vitamin D levels can be very low. Another important factor, which is explains why we are so aggressive about using testosterone, is that testosterone makes bones strong. So men who have Klinefelter syndrome, who have low testosterone levels, this is a very important risk factor for the later development of osteoporosis. So this is a reason we tend to want to use testosterone in men, even though they may have, maybe enough testosterone to grow a beard. We don't think it's usually enough testosterone to maintain a strong bone. There are some other risk factors as well that contribute to the reduced bone mass, and some of this includes genetics. So if you have someone in your family that had osteoporosis, there's a good chance that you might have it as well. We do know that low testosterone levels cause osteoporosis. A normal bone mineral density in childhood and early puberty is important because we see that testosterone deficiency really begins at least the adolescent or the young adulthood times in a man's life who have Klinefelters. It's not 100%. It's not as if like, sometimes I'll have men that, their testosterone levels are fine. They're in the normal range. They're being treated nicely. And they say, oh, I want more testosterone. It's not as finely tuned as that. But generally, you want a man in a nice normal level so that this maintains his bone density as much as possible. And the other issue is that we will measure the DEXA scan to have some sense of where someone is with their bone density at the beginning. So this has always brought up a question about, okay, when should you measure testosterone? And this was a study in which they looked at 20 men who had Klinefelters, and they were started on testosterone prior to the age of 16. And in this population, they largely had a normal bone mineral density. There were some mild changes that were seen in one bone, but it was postulated that, and that might have been due to some differences in physical activity. So men with Klinefelter syndrome who have more fat, whether it be leg fat or fat around their abdomen, these are people that might be a little bit more prone to osteoporosis. And in that situation, we also recommend not only the testosterone, but muscle strength exercises in order to build up muscle as well. most of the growth of bone takes place in the teenage years and in their 20s. So that's why we tend to want to start testosterone relatively early so that men don't lose that thickening that can occur in those teenage years. So once the osteoporosis develops, it's not so clear that testosterone can help it. And that's why we're always thinking in terms of prevention and making sure that we're treating the man with testosterone to prevent osteoporosis at an earlier time. So in summary, regarding bone health, there is an increased risk of osteopenia, that is thin bones, and osteoporosis. There are multiple risk factors for this, including low testosterone. We've discussed the adequacy and the timing, also low vitamin D, and an increased fat relative to muscle ratio. The screening that we recommend is to think about diet, making sure that there's sufficient calcium and vitamin D in the diet. And we always ask questions about fractures and family history. We do recommend a DEXA scan be done at baseline to test whether or not there's any problems with bone mineral density at the very beginning. And we also measure vitamin D levels in certain situations as well. With a DEXA screening test, we're usually able to sort of categorize people, and that helps us determine how frequently to do follow-up DEXA scans, because nobody wants to do these scans every year. And if someone is normal bone mineral density, normal testosterone levels, generally we could say that monitoring should be done every 2 to 5 years. If someone has normal bone mineral density but a low testosterone level, we really make sure that they're on testosterone and then again follow them up every 2 to 5 years. If someone already has low bone mineral density but now treated with a normal T, we look at other risk factors such as calcium and vitamin D. There's also a class of drugs called bisphosphonates, and we would follow this person very closely with DEXA scans every 1 to 2 years. In a group of patients found to have a low bone mineral density and a low testosterone, besides testosterone treatment, we're very careful to consider other treatment modalities that might be used as well to build up those bones, and we would repeat the DEXA scan every 1 to 2 years. So another complication I'd like to mention, although it is generally fairly rare, and that is the risk of cancer. There is a slight increased risk of cancer that can be seen in this population. Britain has a very nice study that was done. They have 3,518 men who had Klinefelters between the years of 1959 and 2002. And what they found that there was a slight increased risk of breast cancer, of lymphoma, and of lung cancer. Studies like this sometimes are not so clear, and the reason is that everyone with Klinefelters is recognized. Not everyone is evaluated in an equal way to see if they have these cancers, but it does point to the fact that we need to be on the lookout for them. It does not mean that a mammogram should be done on all men, but it's something that should be done on a physical exam, and if there's any change, then that would lead someone to a fuller evaluation for the possibility of breast cancer. There's been some other studies that showed that there was no increase in breast or lung cancer, but some tumors that were seen in the chest and the lungs was slightly higher in this population. I still think these are extremely rare conditions, but I want to make sure that the individuals hearing this just know that there's research being done in this area.
Dr. Dobbs?
Yes?
This is Robbie Miller. This might be a good time to ask some questions that have come through here.
Yes.
Somebody wanted to know, should men be getting mammograms like women?
No. the risk of breast cancer is still extremely low in this population. Now, it has something to do with how well you could feel the breasts. So a man who's thin, has no tissue underneath the nipple, then it's a mammogram would not need to be done. But if a man is overweight, there's a lot of fat there, they feel a little lumpy bumpiness, and in that, or any pain, in that situation, the physical exam is limiting. And in that situation, then a mammogram would be done, but it should not be done routinely. So on this slide here, I really make that point, is that a mammogram would be recommended if there's any lump that's felt underneath the nipple, if there's any nipple retraction, any bleeding, or any lymph node abnormality. Otherwise, there would be no need to have regular mammograms done.
So I'm going to assume also then the answer would be no, that they should not be taking, is it tamoxifen or?
Tamoxifen. So tamoxifen is a medication that really is used, it's an anti-estrogen. It's used a lot for women that have breast cancer, and that it's used to sort of block any estrogen stimulation to the breast. If a man has gynecomastia, it's documented that they have some breast tissue there, then sometimes we do use tamoxifen, and it does shrink up that breast tissue, but it would only be used if there is the presence of gynecomastia already. It would not be used to prevent it from happening.
Okay, thank you. And then one more related question. Does the research tell us what is the increased risk of lung cancer if the person does not smoke?
It is not clear what that is. And a lot of the data that I presented to you coming from Britain, where there was at that time, certainly in 1959, the chances of someone smoking was so much higher than it is today. So I do not think that if you that a man who has Klinefelters who doesn't smoke has an increased risk of lung cancer. I think that those studies were confounded by the fact that in Britain, so many people smoked in those years.
Thank you.
All right, so just to continue, and on the bottom, it does say lung cancer. And here is just important to avoid smoking. So there are some other conditions that we talk about a lot. I mentioned infertility already. Infertility defined as the fact that there is no sperm in the ejaculated semen is nearly universal in men with Klinefelter syndrome. There is a great deal of excitement about the fact that fertility is now possible, doing special procedures, doing a microdissection. Here at Hopkins, I do want to say that we are moving to do the surgical procedure earlier and earlier. It used to be sort of said, well, let's just wait until the man is ready to have children, he has a wife, and things are ready to go. But now at Hopkins, we're really moving more to believe that the best time to get sperm is the earliest you can. And, you know, I'm not saying it would be done at 12 or 13, but when the individual is sort of mature enough to understand what's going on, somewhere in their mid to late teens, we are really advocating for early microdissection in the hope of getting sperm that can then be frozen and used later on. And I think that'd be an interesting topic for another symposium such as this. Cognition, there's still, I think, a great amount of questions about this. And I see this because in my practice, I have such successful men. And now whether or not they have learned to overcome some of the learning disabilities, I'm not, I don't really know. But I think there's a very wide range of whether or not there's any learning differences in this population. Psychiatric conditions, we're sensitive to psychiatric problems that can occur in anyone, really. People that have medical problems are more prone to be depressed, where depression is a disease. It's a real disease. We try to treat it as a disease that oftentimes needs to be treated. I always discuss this with patients. One shouldn't be ashamed of the fact that having a medical problem can be a source of distress. So it's something that people need to be, I think about and be honest about. There's lots of controversy about the issue of thromboembolism and whether or not there's any clots that can occur in either the blood or the lungs. There's a slight increase even in the untreated state, and that's because the thought is that there might be a little bit too much estrogen floating around. But there's also concern that with treatment, the testosterone will be a risk factor for thromboembolism. And this has come up with men who take testosterone for other reasons as well, who may not be just Klinefelter's, but for example, pituitary tumor. The data is very, very poor here. It is not proven that testosterone will increase the risk of developing a blood clot. However, this is one of the reasons why I believe that one should not overtreat, and we should try to keep a man in the normal range of testosterone and not make the testosterone level too high, because perhaps too high, there could be this increased risk of an embolic event. Sexual dysfunction is commonly related to the testosterone issue, but certainly can come with cholesterol problems or diabetes, and that's why I am emphasizing the importance of being aggressive about looking for diabetes and heart disease. Autoimmune disease, an example of this is thyroid disease or lupus. Most of these reports came in men who were untreated. They had a slight higher incidence of thyroid and lupus. Varicose veins, very unclear. Again, the thought was that in the untreated state, there might be too much estrogen around, and it was associated with varicose veins. And the issue of dental cavities might be related to the fact of decreased bone density that occurred in untreated men. So I'd like to say a few words about testosterone. I've already mentioned how important it is. Who should receive testosterone? Certainly any man who is symptomatic. And symptomatic would be someone who has a problem with secondary sexual characteristics. And that is someone who may not have gone through a full puberty, someone who's having a sexual dysfunction, that either their interest in sex isn't good or their ability to have an erection isn't good. It's also been shown that testosterone, low testosterone can affect a man's sort of a sense of well-being. It's been very hard to say, what exactly that means. But if you look at large-scale questionnaires, men that are given testosterone have a sort of a better sense of well-being than those men who are left untreated. Another reason to clearly treat with testosterone would be someone who has a decreased bone mineral density. But even for asymptomatic men who have a clear etiology, such as men who have XXY syndrome, the carrier type is consistent, even though they may be squeaking by with the testosterone level within the normal range, that may not be their full potential. So even if a man says, well, I feel fine, there's no really problem, if he is at a range in which we think he may be just, again, squeaking by, we tend to recommend testosterone because we think he hasn't reached his full masculine potential. There are lots of options available. Testosterone gel has been around now for about I'd say probably about 10 to 15 years. There's several types that are on the market. They are all the same. They all have testosterone. It's just they have some different components to it and some different concentrations. Lately, it's been the insurance companies that are telling us how to treat more than anything else, because the insurance companies have worked out deals with the various pharmaceutical companies, so they have favorites, gels that they use. Gels need to be applied every day. Some men think they're a little bit messy. It's just important to always measure the testosterone after you've been on the gel for at least 3 to 4 weeks to make sure you're on the right, you're getting the right amount. Intramuscular testosterone, these are injections that are given once every 2 weeks, sometimes once a week. IM testosterone has been around for about 50 years. It definitely is absorbed in the system. Some men like to take this because it's taken every 2 weeks. You don't have to worry about it. And it also is the least expensive. And that's why many men have really switched away from the gel and more are taking the intramuscular testosterone. The 3 others that are listed here, patches, pellets, and a buccal testosterone, is not used very often. Patches, although they're good, are associated sometimes with skin irritations. Pellets are placed under the skin so that there is some, it's a minor surgical procedure. And a buccal testosterone, this is sort of a tablet that's placed in the mouth. This is often associated with just falling off and not getting very good levels. There are some cautions that I want to mention. The first is that it should not be used in the presence of breast or prostate cancer. Basically, that needs to be taken care of first. It should not be used if there was a palpable prostate nodule. Generally, over the age of 50, we start doing prostate exams. PSAs, if it's greater than 4 or greater than 3 in a high-risk man. A high-risk gentleman would be someone who's African-American or someone who has a first-degree relative with prostate cancer. These are men in whom we usually want to sort of work up if there's a prostate cancer first. Hematocrit, we're very concerned about hematocrit. Testosterone, particularly injectable testosterone, can raise hematocrit levels. So the hematocrit needs to be measured in all men who are on testosterone. There's some controversy about sleep apnea. We generally ask the question, if a man has sleep apnea, he first needs to be treated for that sleep apnea. I don't think testosterone causes the sleep apnea, but we recommend that you sort of deal with that first before testosterone is started. The issue of urinary tract infections, it's not clear that it's related. In poorly controlled heart failure, we are a little bit hesitant to start testosterone, and the heart failure needs to be treated first. This is the monitoring that is recommended. Testosterone levels should be drawn in all men who are on therapy, and we usually look for sort of a mid-normal range. The aim would be somewhere between 400 and 700 nanograms per deciliter. So if someone's taking an injection, we would do this 1 week after the injection. Hematocrit, we're concerned with hematocrits that get above 54%. Think of it as like we don't want the blood to get too thick, and testosterone can make the blood too thick. And if this occurs, we oftentimes stop the testosterone and then reevaluate and figure out if there's another way of administering it. In an older gentleman in which there's concern for prostate cancer, a PSA is measured, and we look oftentimes for what's called a change in the PSA level. You know, how does it change, from year to year? And then lastly is the bone mineral density. And we usually would do this at baseline to see where a gentleman is. And then it's repeated generally every 5 years or maybe sooner if there's any potential problems that are seen. There are some formula-specific adverse events. For injectable testosterone, because the levels get very high after the first day or two, and then a little bit low after 2 weeks, there can be some fluctuations in mood and libido. So this is a concern for some men, and it's something that should be discussed with their physician. This is what's called erythrocytosis, which is a high hematocrit. This is more commonly seen with injectable testosterone. I've already mentioned that patches are associated with some skin reactions, And with testosterone gel, we are a little bit concerned about skin-to-skin contact with women and children, particularly if it occurs within the two hours after application. Pellets can be some infection or expulsion, and buccal, which is that tablet that's placed in the mouth, can irritate the gums or the mucosa. Unfortunately, there is no oral preparation that is available to date. So I want to put a plug in here for Hopkins. There are many very good clinical centers around the country. We see quite a bit of men with Klinefelter syndrome in Baltimore here. This is the team here. Dr. Harati is the urologist who's very experienced at microdissection. Cynthia Monroe is our educational psychologist that does the cognitive testing. David Cook is a pediatric endocrinologist. Chris Kraft is in the Department of Psychiatry. He's very helpful and experienced in these issues of any sort of psychiatric disturbance. This is my picture here. And Kathleen Lawson is a genetic counselor who is just excellent and is really able to explain very clearly what's going on from a genetic point of view. As I say, there are many centers around, but I do know Hopkins. If there is any questions that I can help you with, please don't hesitate to email me. And if any of you are interested in being seen here, this is our telephone number. It's called the Hopkins USA Concierge Service, and this is the phone number to call. Okay, so that's all I have as a formal presentation. I'd be happy to open this up for discussion.
So, Dr. Dobbs, do you see on your GoToWebinar dashboard where you originally clicked on sharing to share your slides, where it has a section called questions?
Oh, wait, hold on a second. I think I...
So there's a number of questions. I think it might be more efficient for you to be looking at them, especially since some of them are pretty technical.
I'm trying to launch it here. Okay.
And your dashboard, yeah.
So the first question was referred to already. Should adult XXY men get mammograms like women, and should they take tamoxifen? So they shouldn't. There is no recommendation to get regular mammograms done. But it should be part of the physical exam that is done with the physician. And if there's any question, that a mammogram should be done. Tamoxifen should not be used. It is an anti-estrogen. It is associated with actually causing osteoporosis. So there would be no need to take it unless there is documentation that there is some gynecomastia there, and the goal would be to shrink up the mass. The next question is there an increased risk of lung cancer if the person does not smoke? And I would say we don't have a clear answer on that. My guess on this is that it is not, and that I think most of the data with lung cancer comes from countries in which there is a higher prevalence of lung cancer. The issue with cancer is that there are some cancers that are related to a genetic cause. And the thought was that if you have one genetic abnormality, such as Klinefelter's, you might have another genetic abnormality, such as some cancer. But the numbers are still extremely small, and there is no clear recommendation that men with Klinefelter should be screened for any one of these cancers. The next is non-nicotine vaping. So, this is a very popular topic in the popular newspapers. And I can't recommend vaping at all. It still has toxins in it. You're sucking it in with through a sort of a fluidy gas thing. So even though it may not have nicotine, there are other pollutants that are in there. Is it better than smoking? Well, probably it is. So it's what's called a risk reduction behavior. It's better than smoking, but I certainly couldn't recommend it anyway. What about pre-sperm material harvesting when azoospermia exists? So, the issue of fertility, again, let me say, this is what I say to every man I see, if you want to be a dad, you'll be a dad. You might marry a woman with children, you might adopt, you might be a foster parent. It takes more than sperm to be a dad. Previously, what most men did who had Klinefelters is they had a sperm donor. They there's numerous clinics around the country. You choose the donor, and this would be it would be a insemination for the woman. So the question for now that the techniques for doing testicular extraction of sperm have improved, in some hands it's as high as 50%. So the question has been timing of this, and there's still some sperm that is in the testes at the age of 12 or 13. But in the ejaculate, already by it's 14 or 15, it really is gone. The question is when to do this. There's a fair amount of controversy about it. I mentioned that we are pushing to do this earlier rather than late. But it's, again, azoospermia, not having sperm in the ejaculate is nearly universal. The next is I'm a KS47 XXY, diagnosed December 2017. I have a medical history of DVTs and a pulmonary embolus, been on anticoagulants for 20 years. Testosterone placement was not recommended. DEXA scan concluded of osteopenia. Well, the question is, what alternatives are there to help slow osteopenia and osteoporosis when testosterone therapy is not an option? So the first thing I want to say, so let me rephrase this question. This is a gentleman with XXY that normally would always be treated with testosterone, but has a history of thrombotic events and has been on anticoagulants for more than 20 years. So this person's physician was very concerned, I assume, that the testosterone was going to increase that risk of developing blood clots. Now, unfortunately, the DEXA scan has already shown a decrease in bone mineral density. So I would have to say there's a fair amount of controversy here. Some people would say testosterone should be used, but it should be used at a low dose. I mean, here's a man that just got a diagnosis, and so he had a coagulation problem, maybe a genetic coagulation problem, for most of his life, for the last 20 years. It had nothing to do with testosterone. So I'm not so sure that why testosterone would worsen this problem. It's an underlying problem that this gentleman has had. We've seen a few patients like this. We work together with the hematologist to determine, the reason why there's an underlying blood clot problem. I'm pleased. I'm not here to diagnose anyone or to say anything about treatment without really seeing the patient. But I think it's worth a discussion. Is that could you still benefit from at least a low dose of testosterone for purposes for at least of the osteopenia? Otherwise, there are some treatments directly for the bone. There is a class of medication called bisphosphonates, or Fosamax is an example of this, and this treats the bones directly. The problem with this is that it has its own side effects, and generally it's used only for 5 years, and then the recommendation is to stop it. And of course, sufficient calcium and vitamin D in the diet, and of course, muscle building exercises are important. But I would not, I would discuss it with your physician and perhaps a hematologist, which is a blood doctor, to see whether or not you might be a candidate for a testosterone therapy anyway. Next question is there a relationship with testosterone treatment and too high a sex drive? So this comes up a lot because athletes who have abused testosterone talk about a roid rage, that somehow they take testosterone, they become angry. And this has not been so clear. But then again, athletes, they're in a whole nother arena. And they're taking way too much testosterone. They're completely abusing it. And that's not what we're talking about here. We're talking about simply replacing testosterone into a range so that you have an average level like every other man in the street. Now, does it cause too high a sex drive? No, not when you're in the normal range. But I have to emphasize, libido is difficult. It's difficult to quantitate, to measure, and everybody's very difficult. It's different. It's complicated. If someone's sex drive is too high and it's a problem to them, then maybe testosterone should be looked at. Or maybe it's really anxiety, and that's something that needs to be addressed. It's not a common complaint to have too high a sex drive, but obviously it can be, particularly if the partner isn't on the same wavelength. So sometimes there needs to be counseling. So I think it's a much more complicated equation than just what the testosterone is. What does high hematocrit cause? So this is where there's the concern of blood clots. There's a concern when the hematocrit gets too high and the blood gets too thick, that there can be a risk of some kind of a blood clot that could develop. And that's why one shouldn't have a hematocrit greater than 54%. What if someone is found to have sleep apnea after they have been on testosterone for 8 years? Okay, so I've already made the statement that if a man has sleep apnea before testosterone therapy, he should treat that with CPAP or weight loss, whatever is being done. And then once that's stable, testosterone can be added. Now, if the man is already on testosterone, I would just treat, I wouldn't stop the testosterone. I would treat the sleep apnea in whatever way is being recommended by the physician. All right. In the future, will there be an oral testosterone pill such as Jatenza that still is waiting FDA approval? So I know I'm not the FDA, so I can't predict this. I'm familiar with with the data. I know there are two pills that are being evaluated. They both work by being absorbed not in the sort of the stomach, but rather through what's called the lymphatic system. So you have to eat the pills with a meal. They're both a pill that have to be taken twice a day. And the FDA did not approve them a few weeks ago, but I wouldn't be surprised if there's some reformulation or retesting that's done so that it might be approved at some point. But for the time being, we're talking about gels, injections, patches, pellets, buccal surfaces. Knowing what to do is one thing. Helping a 20-year-old KS man to motivate himself to do the right thing is another thought. That's exactly true with many, many diseases. One can have diabetes and don't want to take the medication. One can have high blood pressure and don't want to take the medication. It takes an understanding of the disease. It takes a little age and maturity. And sometimes testosterone, I think, can bring somebody through puberty. So you could have a 20-year-old who really has not gone through much puberty, and he's sort of staying in this adolescence. And adolescents are the worst when it comes to being motivated, understanding, and taking responsibilities towards a condition. I think that we're really left with this issue of trying to educate as much as possible, trying to have the person learn that it is it's a medical problem, but a very treatable medical problem, and that all needs a level of maturity to be treated. Next question is, since levels of LH and FSH are abnormal, and this in turn contributes to other problems, is there any research on ways of modifying them into a normal range? Since there are complex feedback loops between the brain and testes, etc., I can imagine that some days there might be a technology that monitors daily or more and triggers dosing as needed, similar to cutting-edge diabetes management. Well, that's interesting. It's very hard to get that FSH and LH level down, and we generally don't. Even when someone is adequately treated with testosterone, the FSH and LH levels still stay relatively elevated. To bring them down, sometimes the level of testosterone administration has to be really high. So I think it's really best to focus on the testosterone level and not necessarily the FSH and LH. But you're right, this issue of technology, testosterone is secreted very differently. It's not given as a BAM injection every 2 weeks. In a normal state, it comes out in these spurts from the testes. And you're right, one of these days, maybe there'll be some kind of testosterone pump that will be secreted into the blood system on a regular basis. Let's hope it happens. The next is, the question is specifically about collecting pre-sperm genetic material, since labs cannot yet grow sperm from this material, but they may be able to in the future. I'm not quite sure what you mean, like spermatogonia. There are some early forms of sperm, and you're right, they can't fully mature themselves, and maybe that will be the future. Is that they could just take a very, very immature sperm and be able to develop that into a mature sperm. Finding KS knowledgeable doctors have been an issue. Endocrinologist and urologist for my son, who's 20 years old, diagnosed at 17. Would your clinic be a source to recommend doctors in other states? So yes, we would. We might be able to help you with that depending on the state that you live in. My honest opinion is that it's worth traveling. I'm not saying travel to Baltimore, but there are other places around the country that's worth traveling to, because there are not that many knowledgeable endocrinologists and urologists around, and I think it's worth a trip to be seen by somebody who really is experienced. This is not the kind of thing that you have to go to, every month. Generally, you see a patient and you could visit them once a year or once every other year. So my personal opinion is that it's oftentimes worth the travel at least once or twice to get a full sense of a medical problem.
Dr. Dobs, if I could add,
Yep.
that Axis has tried to address the issue that question brings up.
Yep.
And on our homepage, you will find links to clinics and members of the Axis Clinic and Research Consortium. And just a few months ago, we launched the professional directory. So these would be a variety of medical and therapy and intervention professionals who have an interest or come to us recommended. And that is also accessible from our homepage. So those are two ways to help.
I really congratulate you for that, and it is important. And you should. And so people that are listening, you should use that list. I think it's so. I shouldn't. Again, I don't know these other physicians, so I can't be critical. But I think it's a waste of time and money to go to somebody who may be, local around the corner, but doesn't know about the medical problem. You're better off just traveling to someone who is really familiar with this condition. And as Mr. Miller just said, it may not even be too far from you. The last question is, I'm the father of a 23-month-old XXY son. What steps, what steps can we take during his childhood that will make it easier for him to have optimal health as an adult? Ideas include having him stand on a vibrating platform a few minutes a day to build bone density, vigorous high-impact exercise as a child, again to build bone density, working with a pediatric endocrinologist to manage hormone levels in some way, and upper body exercise to build strength. Okay, so I think you have to be that different at this point in their life. Most of the bone strength comes teenage years and in their 20s. In the childhood years like this, everybody's level of testosterone is low. So I think what you should do is keep this kid healthy as much as you can, like you would any other child. Making sure that he eats healthy food, that he's active, there's plenty of outdoor play. I don't think you need anything more aggressive than that. And it sounds like being more aggressive than that could be very disruptive, into a household. And that this should be something that the whole family should change. The whole family should be, exercising more and trying to build muscle. And the whole family should be eating food that maintains a normal body weight and maintains calcium and vitamin D in the diet. I would try to hook up with a pediatric endocrinologist. I think that it's very reassuring to parents during these years, even though you're not treating at this point, to help make the decision about when treatment should begin, what age it should begin. But I don't think you need anything more aggressive than the good old-fashioned stuff of loving your child and trying to keep them healthy as much as you can. Okay.
So, Dr. Dobbs, I cannot thank you enough for taking so much of your time
Sure.
here this evening with us. Very, very helpful. For those of you still listening, within the next day or so, this webinar will be up on our website. You'll find it in the library under videos. And there'll be a section called webinars. I also want to thank Endo Pharmaceuticals and Roche Diagnostics Corporation for their support of this webinar series. And lastly, I want to point out that we do have a number of webinars scheduled coming up here in the near future. So please be sure and check the webinar schedule also on our homepage at genetic.org. Thank you again, everybody, for being here tonight, especially you, Dr. Dobbs.
Okay, good night now. Bye.
Good night.